Good evening, everybody. In next few minutes of time, I will be talking on something which we every day get a patient of creeping creatinine and think how to treat them, how to diagnose him, and gets tired, and next day we again start and try to treat them again. This is chronic antibody-mediated rejection. So the aim of the kidney transplantation to me is a one kidney for life with minimal immunosuppressions, with minimal infections, normal or near normal lifestyle, as well as at the minimal side effect of the immunosuppressive. Because in today's world, tolerance may be a slightly far from a transplant scenario, but it is more close to a tolerance, the one kidney and one life. But this is not that easy because so many things happens in the transplant patient's life, starting from the early delayed graft function, donor-related factor active rejection, to chronic factors such as recurrent glomerulonephritis, de novo nephritis, chronic rejection, CNI toxicity, etc. So the life is not that easy for a transplant patient, and this is the most important cause of the left allograft failure in different studies, from the American statistics to the world statistics. It is the chronic antibody-mediated rejection plus minus with the T cell rejection, the commonest cause of chronic graft dysfunction. And this is not very far from our findings. In our 2000 biopsies in our hospital, we found around 50% cases chronic rejections, antibody-mediated plus minus cell-mediated, the commonest cause of the chronic graft loss. So chronic active antibody-mediated rejection is the leading cause of graft failure, and it represents a chronic immune injury to a donor-specific antibody that is present in the blood. And it is not a mere histology, although it is represented in the histology as a features of the chronic tissue injury. So it is a spectrum. It is a continuous process which starts with the development of some antibodies, which may be due to several factors, which ultimately involves the complement, which affects the endothelium of the kidney. And if this inflammation, treated or untreated, remains in a subclinical stages over the years, smoldering, it induces to the chronicity. So it's a spectrum which starts from an initiation of the antibodies to the inflammation to the chronicity is a continuous spectrum, not only histopathological report. Just the pictorial representation, you can see in the first part there is formation of the antibodies, and followed by there is involvement of the complement, and subsequently there is a tissue injury. So in the initial phases we get in the blood only the antibodies, and there is no inflammation in the kidney, and there is no evidence of subclinical injuries even in the protocol biopsies. And subsequently when the inflammation goes on and it causes a graft dysfunction, when it is chronic it causes a proteinuria, hypertension, worsening of the graft function. So it is a continuous spectrum. And you can see the initial phases. In some situations there may be accommodation also. The antibodies are there that may not produce any clinically evident injury to the kidney, and in those situations the graft survival is much more. It happens in two ways. One, which I have described, there is some indolent ABMR is there. You can see there is antibodies are developed that causes some inflammation. That is a subclinical way, not treated, ultimately causes a chronic graft dysfunction. We call it chronic ABMR. Or it can be there is an initial phases, the de novo antibodies are present. Immediate post transplant period, you can get fluctuations of this creatinine and inflammation that is treated clinically totally, but probably subclinically partially, and ultimately they can also cause a graft dysfunction. So it can happen in two ways: chronic persistent infections or acute recurrent inflammations. So if you see this, this is spectrum is a ABMR continuous spectrum. The active antibody-mediated infections are usually there is a subclinical and clinically apparent. It may be this is associated with some chronic changes in the biopsies. This is associated with C4D deposition, and the clinical serum DSS may be in different situations. If you don't treat them, they'll end up in a chronic dysfunction. We call it chronic ABMR, maybe chronic inactive ABMR initially previously it was called, and that is the commonest cause of permanent graft loss and a very poor prognosis. This is 2019 classifications of of the BAMF classification, which defined that chronic ABMR requires, as other ABMR, chronic active ABMR requires the presence of these histological criteria like glomerulopathy and the peritubular capillary multilayering, along with arterial intimal fibrosis, plus 2 and 3 means C4D deposition and presence of DSA. You can see this is the slightly complicated in 2019. I was telling all these things because this is a continuous spectrum and there is lots of confusion. So there is again and again there is a change in the BAM classification also. In 2022, the latest guidelines which removed this arterial intimal fibrosis as a part of the ABMR diagnosis, and other criteria like 1+2, 2+1, 2+3, these criteria are also removed, and chronic inactive ABMR is now called it a chronic ABMR. So we have chronic active ABMR with active inflammation, with a chronic ABMR that is without inflammation. So this is chronic active ABMR, chronic AMR with antibodies, with C4D, and with histological changes. But these things are okay because there are so many factors, because it's a clinico-pathological situations. In this situation, we need some de novo antibodies to be present that can develop because of so many reasons. There may be the de novo antibodies should have reacted, or they're according to their nature, they have reacted with the endothelium. There may be some non-HL antibodies, there may be some complement binding versus non-complement binding antibodies. Ultimately, there are some histological features. So there's so many things that are involved in the diagnosis of the chronic antibody-mediated rejection, not only in histopathology. These are some pre-transplant factors, and these are some post-transplant factors which ultimately leads to this entity. And these are things that has been highlighted over the years, which has been an important etiological factor for the development of this chronic. But the pivotal to this chronic antibody-mediated rejection is the presence of the DSA. Wherever the DSA is present, in presence of rejection, inflammation, it creates a bad outcome. Just is censored graft survival according to the AMR in the DSA status. This is the DSA positivity in presence of acute antibody-mediated rejection, or without it, it is a bad prognostic factor. So you can see the graft survival according to the DSA status. If you just follow it up following the biopsy in different days, those who are biopsy positive ABMR plus DSA positivity, they have a worse outcome. This is the same thing, early AMR plays a poor diagnosis. But this, along with the DSAs, there are so many confusions in the histological diagnosis. Many of the histopathological report may not confirm, they may not justify or confirm this BAM criteria that has been given. So there has been always been a search of these biomolecules, that is the biomarkers from this acute antibody-mediated rejection. Whenever you get some confusion in the biopsy, in those situations, you can test for a donor-derived cell-free DNA, that is the evidence of the tissue injury of the donor's kidney. There may be some mRNA gene signatures, or there may be some urinary biomarkers like CXCL9 and 10, etc. If these are included along with this, there is also some genetic panels. There is a BAM-FOT panel, the Human Organ Transplantation Act panel that has been given by the BAM. There is genetic analysis. In those situations, particularly when you are getting a biopsy that is not confirmatory of ABMR, you can include them to get a justifiable diagnosis to plan for its treatment. So that is always the utilizations of this artificial intelligence with all these factors. These are clinical factors, so these may be genetic factors, these may be serological factors, and the histological teats and beats. And over the years, it has been seen that this intelligence box can predict the graft outcome slightly better than that of a humanized one. So these things, ABMR is not a simple thing nowadays, it is a complex one. It starts with the histology, C4D, DSA and electron microscopy from the histopathologist, then goes to the clinicians, and then to the data scientist, and ultimately an algorithm develops, or this may be in the PDF or the Excel, and that can guide you for the diagnosis, just not a diagnosing of kidney biopsy, creeping creatinine, and you start the treatment, not like that. So decision making is important for this disease. So how the treatment varies over the years. There is no specific guidelines. KDIGO has never given a good guideline for this treatment of AMR. There is nothing mentioned about the chronic antibody-mediated rejections. Best of the clinics have given, you can see this is a Mayo Clinic recommendation. They have given much less importance to the diagnosis treatment of this chronic antibody-mediated rejection. And this is more frustrating. In Europe, there is a nephrologist, they have been questions regarding for not prescribing further treatment of ABMR. This is around 52 nephrologists who has been transplant physician practicing for 3 to 30 years. They has been asked, and you can see 67% of them responded that there is a disease was too severe, there is no convincing therapy for that, and only 12 to around 33% they have control effective optimization of the immunosuppression they have done, and newer drug utilization was much less. This is another one, this is another survey in the 56 nephrologists with 30 years experience, 3 to 30 years, and who are dealing every day at least the patients for this chronic antibody-mediated rejection. And when they were asked how do you treat them, About 70% responded with the steroid pulse, 70% with the IVIG, apheresis is 62%, rituximab is 50%, tocilizumab is 30%, and the rest of the drugs are much less. So there is no unanimity. The question is that there is no fixed answer for treating of such a disease. But some centers have shown if you treat them knowingly or unknowingly more aggressively, this is a definite data of indicating 82 patients of chronic antibody-mediated rejections with multiple drugs compared to that of a standard care of treatment, the outcome is slightly better. Early aggressive treatment is this is a single center experience, slightly maybe bias should be there, but this is an indications. So only optimization of immunosuppression may not be a good option. Then what are the good options? For this in 2019, there is a TTS, the Transplantation Society asked for a consensus guideline for the formation of the consensus guideline for the treatment of chronic active antibody-mediated rejection involving more than 25 scientists all over the world. And they have talked with so many things in the pathways and the drugs in different levels. But ultimately, nothing worked out. They also told that if there is a chronic antibody-mediated rejection, you optimize the immunosuppression, add steroid if this is a steroid-free regimen. You can sometimes give an IVIG, that too is a class 3 CE evidence, plasmapheresis and rituximab, that too. So nothing more than that. But what is a fruitless thing to give such a conference? But there has been lots of discussion amongst the drugs which acts in different levels of this. This is a B cell mediated or the antibody antibody producing pathway, slightly upstream, slightly downstream, starting from the belatacept to the CD20, rituximab, bortezomib, daratumumab, and this is eculizumab. So many things has been discussed. So the protocols was not decided. And it was always a learning curve for a disease which we deal every day with inadequate response, and not at all a smooth road. Whoever has been treated a chronic antibody-mediated rejection, escalating or de-escalating the dosage has given you lots of problem to us. So the drugs which has been discussed, the first one, the rituximab, has been discussed. Depending upon the reports available or the trials available, most of them are retrospective and single center studies. One is only this is a placebo control, randomized control trial. In the single center experience, rituximab was found to be effective in treating the patient of patients of the chronic antibody-mediated rejection, but it's a single center retrospective and there is a selection bias. But this is an important, it's a concert study which compared, this is a randomized control trial, compared few patients, only that they had 12 patients for the patients with rituximab for chronic antibody-mediated rejection, and showed no benefit. So probably the 16 studies, mostly they are retrospective, 1 randomized control trial, 7 are the chronic antibody-mediated rejection, and because rituximab was not found to be very much effective, but still it can be utilized because it is of not much of cost and side effects profile is much less. Second, not true that for the proteasome inhibitors like bortezomib and this is carfilzomib, and this has been tried and shown to be ineffective in the treatment of such cases. This is a Borteject trial which showed the effectivity of the bortezomib in treating chronic antibody-mediated rejection. There was no effect, rather there can be more side effects and more death in the bortezomib group. You can see this is a graph survival. This is survival is much less in the bortezomib group compared to the control group. But the slightly encouraging results has been found on the interleukin-6 receptor, this is tocilizumab and clazakizumab, and they have been studied in 2017 and 20. This is the Stanley Jordan's experience. They have done in 40 patients, utilized this monthly dosage of the tocilizumab 8 mg per kg. They had been followed it up till there is a 1 year period. There is a biopsy follow-up, and they have shown that there is a preservation of the GFR. There is some reduction of the chronicity of this chronic antibody-mediated rejection, and is reasonably safe. But they concluded that tocilizumab may stabilize the renal function and histological injury in chronic antibody-mediated rejection. So this is another interleukin-6, tocilizumab versus standard of care. This is an Asian study which showed that tocilizumab gives a better response compared to the standard of care. And clazakizumab, which was initially studies based on the 2 randomized control trial in Vienna and the Berlin, and they have shown to be not effective and more side effects in treating the clazakizumab patients. And this is an ongoing trial. This is an Imagine trial involving, this is almost 350 patients, which is supposed to be completed in 2030 for the treatment of tocilizumab for the patients of chronic active antibody-mediated rejection. And they had been followed up, but it is stopped prematurely because the trial was unlikely to give some benefit, although the side effects profile are not high, but it was stopped because it was of no benefit. So the tocilizumab although shows some promises, but the randomized control trial has failed to show the benefit. This is another Sandy CD38 monoclonal antibodies, the daratumumab. This is mostly plasma cell mediated injury and chronic antibody mediated rejection. And if this is the CD38 positive cells, they have shown to be some benefits in the terms of reduction in the DSA, some reduction in the chronicity, but ultimately there is an withdrawal. Upon the withdrawal of the drug, there is rebound, and ultimately the effect is not there. Rather than, this is a felzartamab, this is another CD38 blockade. They have shown that safety profile, you can see there is a safety profile is quite good compared to that of the previous drug, and this is but not much effective in treating the patients. Only the DSA is reduced with a potential therapeutic benefit maybe in the chronic antibody mediated rejections. Complement by the mediated based therapy is mostly promoted by the Professor Montgomery from USS at different levels, seculizumab, C1 complement inhibitors via this is monoclonal antibodies, but these are of limited benefit and they are of not been studied. So ongoing trials are those I am already shown. But one important thing I want to highlight is the old drug with the new options. This is intravenous immunoglobulin that has been studied in different trials, either retrospective or a prospective way, and showed some benefit without much complication like side effects like infections and etc. This is an important recent trial that has been published in Kidney International in 2025. Here they compared 15 patients with the chronic antibody-mediated rejection. They have given 6 months monthly dose of 1 gram per kg per month dosage of IVIG along with 250 milligram 3-day methylprednisolone, and next 6 months they have studied. They have studied in terms of the GFR, in terms of the histopathology, in terms of gene expression, and they concluded that in kidney transplant patients, the chronic antibody-mediated rejection IVIG therapy stabilized the kidney allograft. Histology was stabilized. GFR benefit was not much, but the histology was stabilized, gene expression was reduced, and the graft remained stable with reasonable safety without increased evidence of infection. So this is an encouraging result that has been found is a well designed and very sophisticated trial that has been published recently. So in our hospital, we have also tried in few patients, about 60 patients of chronic antibody-mediated rejection, biopsy proven by giving these high doses of the immunoglobulin. Here we give about 2 gram per kg immunoglobulin for over 6 weeks, weekly doses, and we followed them over 3 months, 6 months, and the 12 months. This follow-up was done by the donor-derived cell-free DNA. Repeat biopsy was not done. Groups are comparable to each other. But at the end of the 1 year, we found some benefit in terms of GFR. GFR trajectory is improved in the patients who received the high doses of the IVIG. There is the MFI changes is also significant. MFI is improved. That is, DSA has been reduced with the high doses of the IVIG, and the donor-derived cell-free DNA percentage has been reduced to the subclinical level. That is from 2.5% to around less than 1%. So lots of things are going on in this field of chronic active antibody-mediated rejection. Not that we should not try, but we always should try to cope up this research because there are multiple pathways. We are not targeting one path is not enough. We have to affect the multiple pathways. So some hope is there. You know, there is a peripheral immune tolerance. This is a Nobel Prize that has been given to the medicine in this world, in this year for this autoimmune diseases. Let's hope for the best. We develop something which is very close to the tolerance for the chronic antibody-mediated rejections. So to conclude that chronic antibody-mediated rejections is a leading cause of graft loss, and there is no approved therapies. Early aggressive therapy is important. Functional markers should be used like that of a DSA proteinuria, and the personalized approach is most important. So thank you very much for the listening. Thank you.